Good evening, everyone. Thank you so much for joining us tonight. Tonight's topic is primary care identification and management of thrombosis with thrombocytopenia syndrome. And tonight we're lucky enough to have the Associate Professor Nigel Crawford, who's the Director of Surveillance of Adverse Reactions following Victorian in the community. We've also got Dr. Anita Muñoz, who's the Chair of the Victoria Faculty of the Royal Australian College of General Practitioners, and myself. And now I'm no expert in TTS. I'm a GP that works primarily in paediatrics, but I do know how to write health pathways. So I've been guided to write a health pathway on this following the recent cases that we've seen throughout Australia. Next slide. I'd like to start by acknowledgement to the country. In the spirit of reconciliation, we acknowledge the traditional custodians of country throughout Australia and their connections to land, sea and community. We pay our respect to their elders past and present and extend that respect to all Aboriginal and Torres Strait Islander peoples today. Next slide. The webinar is being recorded and all attendees currently are muted. There is a question and answer button which you can ask some questions during the evening, and I will try and get to those and incorporate some of those that, especially if they're repeated by a number of GPs, incorporate it in our question and answer session at the end. Don't use the chat one because that won't work. So use the Q&A one. And afterwards, the slides will be circulated to the attendees, and also there'll be a CPD certificate, which will be uploaded for you to your appropriate college. So for the first, initially we'll have an introduction, and then following this, Associate Professor Nigel Crawford will go through some of the clinical aspects of TTS following AstraZeneca, and give us the updated risks in each age group. And we talk about how to identify the patient that comes into the room. And also then following that, I'll go through the health pathway that's been written to be used as a tool at the point of care. And then shortly after 7, Anita will help us with coping with the questions with the patient in front of you, who often will have some very curly ones for us. Following this, we'll have a question and answer section with a panel, and then we'll close. Next slide. So the objectives tonight are to increase primary care knowledge, assessment and management of potential cases of TTS turning up following the AstraZeneca vaccine. And Anita will provide a framework on how to deal with these questions related to this from the patient in front of you. Associate Professor Nigel Crawford will now give us a clinical background. He's the Director of SafeVic, Medical Head of Immunisation Services and a Consultant Paediatrician at the Royal Children's Hospital. And he's also an Honorary Principal Fellow at the University of Melbourne, Department of Paediatrics, Group Leader, Infection and Immunity Theme, Murdoch Children's Research Institute. So I'd like to hand over to Associate Professor Nigel Crawford.
Thanks very much, Scott, and thanks for the opportunity to present today. Yeah, it's a real pleasure to talk to primary care colleagues, and again, acknowledge to Scott to sort of generate this discussion, because I think it's been recognised that there is a lot of questions coming around TTS that are coming through GP practices, and never more so than the last few days through the media, etc. So I think it's a really good opportunity to start to discuss these issues, and I'll take you through some of the current evidence and hopefully answer some of the Q&A at the end. Just declarations of interest, always a good thing to flag before any talk. And as Scott nicely outlined in my introduction, I've got roles at SafeVic. I'm also currently a Senior Medical Advisor at the Victorian Department of Health. They've obviously stood up a large team to help with the rollout, which includes vaccine safety and evaluation group, which I've involved with, and I'm also a member of ATAGI. So it's always really important just to outline right at the start of the presentation on my own views, not necessarily those of my affiliations, but I have no pharmaceutical industry declarations for this presentation. Next slide, please. So I think the first thing to say is what is TTS? And, you know, as a background, we as the vaccine preparedness was happening, we're working with international colleagues to have a really long list of what's called adverse event of special interest, or AESI. And these included a whole list of different conditions, some of which were seen in clinical trials, some of which have been seen in other vaccines as part of that sort of pharmacovigilance. So phase 4 programs were set up to start to monitor for some of these. So lots of evaluation through the big phase 3 trials, but we know as vaccines roll out, we may not pick up particularly rare adverse events until they rolled out to larger populations, and TTS certainly fits that bill. And thrombosis itself was important. So people were already looking at both pulmonary embolus, DVT, as well as myocardial infarction were adverse events of special interest, as was thrombocytopenia. Immune thrombocytopenia, or ITP, has been described post most vaccines, including COVID-19 vaccines. So thrombocytopenia as a differential was included, but not this combined syndrome. So what's important here, that it's thrombosis with thrombocytopenia. So it's those two in combination, so it's TTS. And we prefer to use that term for most of the descriptions because there's also other conditions that might lead to you having thrombosis with thrombocytopenia. So for example, a malignancy may be associated with an increased risk of thrombosis, and your platelets may be low because of your diagnosis or your underlying treatment. So the two can happen in combination, but this unexpected but important adverse event does see those two in combination with some other features we'll go through. So if it is shown to be in the vaccine window, classically sort of 4 to 30 days, but out to 40 to 42 days, then we call it vaccine-induced thrombotic thrombocytopenia, or vaccine-induced prothrombotic immune thrombocytopenia, or VIPIT. We like our acronyms in vaccine safety. So there's a list there. Next slide, please. So in terms of the etiology, I've given a reference there from Greinecke. He was the first person in Germany to identify the antibody that we believe makes this an immune-mediated phenomenon. There were cases in Europe, including a case of TTS in Austria, and then some in Germany and Scandinavian countries where they identified this antibody. But the exact etiology is still unclear, but it's very similar to heparin-induced thrombocytopenia, or HIT. So this is a condition that can occur with heparin exposure where you do get thrombocytopenia. And this Greinecke was an expert in HIT. And when he heard about these cases, he went into his lab and found this antiplatelet factor 4 or PF4 antibody. And what's important here is that it's a platelet activation. So rather than the ITP, where you tend to get a drop in platelets, you'll often have mucosal petechiae or nosebleeds or gum bleeds or other forms of excessive bleeding. With this particular syndrome, while that may occur, majority of times you won't see anything physically because of the low platelets in terms of clinical signs. Even though you'll look for them, they often don't find them. It's more that the platelets just are low on a blood test, and there are thrombosis, which we'll talk about the locations and some of the unusual places in the next few slides. So that's just a bit of background, and the New England paper from Greinecke is one of the important references for this condition. Important to say it's not causally associated with the mRNA vaccines. There's been over 180 million Pfizer and Moderna vaccines administered in the United States, and no causal association in all of their reviews. So confident that this is not part of the mRNA platform. It's very much seen with the adenoviral vector, so with the AstraZeneca vaccine, and also with the Janssen or J&J vaccine, which is not being used in Australia, has had cases outlined in the United States. So confident it's not linked to the mRNA vaccines. Next slide, please. So this slide just talks through a bit more detail that pathophysiology, and this is the heparin exposure, or the HIT, which is essentially production of that PF4 heparin complex. It's immune mediated, so it triggers those B cells to produce IgG. That activates the platelet through that FC receptor. And then those microparticles are stimulating the platelet aggregation and then secondary thrombosis. So just saying, I'm definitely not a hematologist, and I know our fans, colleagues, the Hematology Society, Hugh Tran and Vivian Tran and others have spoken at a few forums, but clearly very important their input into understanding this mechanism, and also the treatments we'll talk to a bit later. Next slide, please. So as mentioned at the start, I think a key thing as you're discussing this syndrome, Anita will go through some of the risk-benefit discussions, is understanding what the current rates are in Australia. So we know as this emerged out of Europe, there were different rates coming out of the UK, quite a few programs, including Scandinavian countries such as Norway, reported case series and stopped their AstraZeneca program. Clearly in Australia, it is a very important part of our program, so we needed to understand the rates, and now we have prospective data collection with over 60 cases in Australia, of which we can then estimate that by age, bracket or band. So what's been happening recently is that ATAGI, as you know, has given some guidance around this and is still meeting weekly. So we're meeting every Wednesday to discuss the current cases as presented by the TGA, who then also on a Thursday produce a list of where we're up to in terms of TTS cases and management as part of their weekly report. And then an ATAGI statement follows in terms of advice to the program. So there's an important sort of clear cycle, and the link there to the ATAGI statement from last week, and that'll be followed up with another statement, updated statement tomorrow. But as of last week, as you can see there, definitely a higher rate in the under 50s, and that had increased over time to 3 per 100,000, or 1 in, say, 33,000 doses. And the 50 to 59 was in the 1.4 initially, but has increased up to the 2.4. And then the recommendation came to change the preference for a Pfizer or mRNA vaccine in under 60s. And you can see the rates there in the 60 to 69 and the 70 to 79, and those over 80, both under 2. So there was a cutoff initially of that 50-year-old cutoff, but now it's moved to 60. So it's 2.6 per 100,000, those less than 60, and 1 per 6 per 100,000 in over 60. And those rates will be updated through those links. Next slide. So this importantly shows the data by severity. So rather than just the rates, it's important to know what the severity of these conditions are. And as I mentioned, there's some unusual locations. So the CDC came up with a classification which is now being considered in these cases. So rather than just the rates, we're getting the tiers. So tiers an unusual location, and as I'm sure people have heard, it's the central venous sinus thrombosis in the brain, or a splanchnic circulation in the abdomen are the unusual locations associated with those thrombocytopenia with or without the anti-PF4 antibodies. And then tier 2 are those found in the more common locations, such as a DVT or PE in the lungs with low platelet counts and PF4. We have seen a mixture of those across the age range. So you can see on the table there that we've only had a very small number in those less than 40, only 2 cases. But again, not a large number of doses given to the age range, given they weren't part of the prioritisation by age or risk factors initially. Having said that, if you are obviously a 1A healthcare worker or worked in hotel quarantine or our borders, or if you were in a 1B, as we were making our recommendations, you may have received some doses, but small number of cases in those age groups, 4 in the 40 to 9 age group. And then you can see the mixture of the tier 1, tier 2 cases over the different age range. And probably the key thing to take home here is just in that under 50, you can see there's 6 cases, and 5 of those were tier 1. So definitely this phenomenon in terms of TTS does seem to be more severe by younger age. That's certainly what was experienced in Norway with the younger age range of more severe cases, and then the cessation of their program or pausing of the program and looking at those age ranges. So I think it's important to see those rates, and again, haven't changed dramatically given the relatively small numbers of AstraZeneca giving to those age groups. Next slide, please. So in terms of case fatality rate, it has been low in Australia relative to other countries. We've had 2 confirmed deaths due to TTS. Again, very close follow-up with our haematology colleagues, as mentioned, and we'll go through some of that in the health pathway, but clearly identifying cases as early as possible, non-heparin anticoagulation and intravenous immunoglobulin being administered early in recognition is an important part of that treatment process. But this is giving from the UK, which again, obviously run a different program in terms of rolled out by both healthcare workers, predominantly got Pfizer initially. They then went down the different age grades with a mixture of both AstraZeneca and Pfizer vaccination. So they haven't given a huge amount of doses of AstraZeneca to the younger age groups. You can see there the table. This is their weekly report. So again, if you want to find the updated slide, you can go to that link. And this is their table of both reports by age range and number of failure reports. So for the 18 to 29, they've had 27 reports or 6 deaths, so close to 25% fatality. Again, quite high fatality rate, 22% in the 30 to 39. And then it is variable over the different age ranges with, I think, now 17% overall. So this was potentially partly to recognition, acknowledging true the UK was clearly in the middle of a major COVID-19 pandemic with huge impact on the National Health Service in terms of case burden and deaths due to COVID. So that risk benefit, again, Anita will touch on, is really important to put this into context. But I thought those overall numbers of fatality from the UK is just an important bit of information to be aware of. Next slide, please. So in terms of the features of that thrombosis, I've touched on some of this already, but it's the 4 to 42s post-vaccination, but majority seen around the 2-week mark. So being aware for these symptoms is really important. And in terms of the presentation, often the organ-specific symptoms is where they'll come from. So if it's a CVST, there may be an unusual headache and other features associated with that in that time window, may go on to some of those red flags we'll touch in a bit later. The splenic vein thrombosis with the abdominal pain, and then as mentioned, DVTPE, and some rare arterial or other sites of thrombosis, which are uncommon, but also important to be aware of. Important to note they're predominantly been after first dose AstraZeneca. In Australia to date, from last week's report, we haven't had any cases post-dose 2, but clearly looking closely to that, and the TGA will continue to report on that, including their report tomorrow. Important to note that they haven't had history of heparin exposure, so it's not a HIT-like syndrome in the cases that have been confirmed here in Australia. And that UK data is also reassuring. They've had, I think, 27 reports post-dose 2 vaccine, and closely monitoring for the risk factors but certainly a much lower rate with that dose 2, hence the recommendation here in Australia to continue, importantly, with that dose 2 AstraZeneca dose. When you're asked to present for that second dose, we are recommending that they receive their dose 2 AstraZeneca. As mentioned, the thrombocytopenia, 150 is the level. So knowing that, how low it is, and then the trajectory is also important. So it's possible the very first test, it may be borderline. So we need to think about it if its symptoms are ongoing. That further evaluation will go through in the pathway. And the D-dimer, very high. So unexpectedly, it's up to over 5 times normal is part of the criteria with the hematologist. And then if they do fit this criteria, you can send them off for the antibody, which goes through the hematologist, and normally a hospital request. And currently that's being done out at Monash Laboratories, are doing all the PF4 antibodies for us here in Victoria, with other labs around Australia also undertaking that. So they're both the clinical signs and some of the investigations for TTS. Next slide, please. So as mentioned earlier, that investigation is really looking for the sites and symptoms. So as mentioned, the significant, ongoing, unusual, persistent headache, maybe some blurred vision or focal signs, would then clearly progress to brain imaging, including CT venograms or MRI, with looking closely at those vessels. It can be a hard neuroradiology diagnosis to make, so important for experts to review that. As mentioned, avoiding heparin and giving IVIG as appropriate, plus steroids may be used in some cases. And this paper highlighted here is just a New England paper, came out last week, showing how difficult can be managed in some of these cases in intensive care, and the platelet count can fluctuate, and that activation can be a hard thing to switch off. And that was an important paper, just showing us, some of the complexities of managing TTS, particularly the central venous sinus thrombosis cases. Next slide. So maybe just last comment to mention, I think this will come up also in the Q&A, is while we've talked about the rate and incidence and fatal cases, there will almost certainly be in quite a few of the cases, particularly those tier 1, some ongoing morbidity. And we are getting organised through the service I'm with at SAFIC here in Victoria, but also nationally, and then through the TGA collating these cases, is understanding the morbidity. What's the outcome from those that have had CVST, and what's some of the longer term complications, both from the medical side, but also some of the, mental well-being and things that may be associated with this condition. So really important to, understand this condition to best give that advice moving forward. But I might hand over back now to you, Scott, to talk through the HealthPathways. And I know it's been a collaboration brought together through the Australasian College of Emergency Medicine, the FANS group that I mentioned, and also some ATAGI primary care guidance, which is coming and help feed into this. Thanks, Scott.
Thanks, Nigel. Now, the next slide, I don't want you to look too closely at, because it's far too small, but there's some headings there. So those of you that are familiar with HealthPathways will understand this slide, because we have 5 headings: the red flags, the background, assessment, management, and referral. Now, this is the specific pathway, health pathway for vaccine-associated thrombosis and thrombocytopenia. If you're looking at the health pathways as a whole, we have a number of COVID vaccination pathways that basically will cover a lot of other issues in vaccination, but this is very specific to the possibility of TTS that can occur in the patient in front of you. So we'll go to the next slide and we'll slowly dissect this. So in the assessment section, basically we wanted to write this pathway as the possible symptoms that may be raising a concern that for a patient that presents if they're within that 4 to 42 window following the first dose of AstraZeneca. So with the assessment, we have a drop-down box, and then we have an examination section, and we have an investigation section. So if we go to the next slide. So the symptoms of a thromboembolic event, and the most important thing is sometimes these initial symptoms are mild and gradual. So we're talking about day 4 to 42. So if it's the first 24, 48 hours and they've got a headache, that's an expected side effect. But if we're within the 4 to 42 days period and the patient comes in and clearly it's an unusual headache, or it's someone who doesn't normally have any symptoms, you'd start to think, yeah, I probably should be treating this seriously, even if their examination and clinical presentation is reasonably comfortable. You'd probably want to go through and perform some investigations. So the symptoms that we tend to see most commonly for the tier 1 are obviously the headache, which is suggesting a cerebral thrombotic event such as venous sinus thrombosis, a new onset headache that is persistent, progressive, or unusual, worse when supine or bending over, like the raised intracranial pressure kind of headache. They may be associated with some other neurological features, which clearly will put into a more urgent category. With the abdominal symptoms, that can be very difficult. So unusual abdominal and back pain, which may suggest splanchnic venous thrombosis. And there may be associated with nausea, vomiting, diarrhea, and even fever. And fever has also been seen with a headache, which is interesting, and profound fatigue. Now, the tier 2 are the classic DVTs, the pulmonary embolism kind of, DVTs that can potentially lead to a pulmonary embolism. So certainly keep in mind those kind of secondary complications that can present. And then we do have some unusual arterial thrombosis, where basically we'll have an obstruction to an artery, particularly a limb, or even a myocardial artery, which result in some ischemia. So that's first drop box. The next drop-down box is simply a reminder of the symptoms of thrombocytopenia. This is a more unusual presentation of TTS, but certainly if anyone presents with petechiae or unexplained bruising or bleeding, then consider following the rest of this pathway. Next slide. So the examination was basically assessing the vital signs, and then guide your examination depending on where the primary site of symptoms goes and comes from. And then I didn't go through an extensive examination. I expected that would be sort of understood by GPs there. And then the third part is, if anyone is presenting with unusual features, the most important thing is to arrange a full blood count and D-dimer. And the criteria there is the patient is sitting in front of you and seems quite clinically stable with mild symptoms and no real significant clinical findings. The other factor here, particularly for the rural GPs, we'd like to see the results within 4 to 6 hours. Now, 6 hours is more manageable, and we felt that was more appropriate, but we have to have a caveat there about what would you do if you did get it at 6 hours and you are living a long way from tertiary centres. So the individual circumstances, which is on the next slide, is sort of the common sense kind of things. You're able to do the bloods and keep them in primary care. If you can easily contact the patient is safe, they're not alone, and their distance from a tertiary emergency department is acceptable if escalation is required, and also the time of the day. So you wouldn't be sending them off for a blood test at sort of 3 PM if we know that they're not going to be able to get those results back. So the next slide. So the management is quite simple in the point of if you feel that the patient is not stable, then they need to be in a tertiary centre where they're going to have extensive extensive evaluation and radiological investigations that are really outside the domain of the primary care. And so you'd pull the trigger on sending them to the emergency department, obviously if they're clinically unwell or you suspect a possible TTS, but you can't really get the bloods in that time frame. And then the specific full blood count, which shows a platelet count of less than 150 and a D-dimer greater than or equal to 5 times the upper limit of normal. And now the platelets can sometimes be to a late depletion. So if the platelet count's normal, that's not necessarily all okay. The D-dimer is the clue there. Sometimes the bloods will take a little while to evolve, and so if the patient continues to have symptoms, you would repeat those bloods the next day. So the last part of the management there is patient has a differential diagnosis that requires further investigation and management that is not available in primary care. The second part of management, if the patient doesn't have an emergency department kind of issue, and the patient presents with a headache, then follow the headache pathway, and then other symptoms you can manage according to the likely diagnosis. If there's possible thrombosis but the bloods are normal, then you basically manage that following the health pathway for a DVT or a pulmonary embolism or another thrombosis kind of event that's occurred. For all these cases that are mild and they have normal bloods, you'd arrange your next day review. But if the patient deteriorates, then they certainly need to attend an emergency department. But if they do turn up the next day, you consider repeating the bloods if the symptoms are persisting, or even pulling the trigger on sending them to the emergency department. So we'll keep going to the next slide. Oh, I did have, so that's basically covers it. The referral section is basically a repeat of the management. So next we're going to have a look at some of the questions you're going to get asked and how to deal with them from Anita Muñoz. And so I'll hand over to Anita.
Thanks very much, Scott. Thanks very much for the invitation. I'm very pleased to be here. I understand that it's actually really interesting times that we're all living in, and things are rapidly changing. And general practice, being the amazing super specialty that it is, I think is used to pivoting now in this pandemic. But I also think that if we're going to do a good job of continuing to change with these times, the key to that is information. So that's what we're here to provide, to give all of the GPs in the state a good basis upon which to have discussions with their patients. I'm Anita Muñoz. I'm a GP, of course, and I work in Melbourne CBD. I'm heavily involved in medical education, and I'm the chair of the Victorial faculty at the Australian College of GPs. Next slide, please. So this is definitely not a small topic, and there's a lot that you could say on the issue of counselling patients who are coming in to have an AstraZeneca vaccine, given the changes that have been described. But I'm going to make a point of keeping this discussion really at an overarching level, rather than delving down into very specific, numbers and age stratified risk, etc., because we will provide links and resources for you to get that kind of detail. The approach that I'm going to take tonight really is a framework for dealing with these conversations, and some tips and tricks that I've been picking up in participating in a lot of webinars and groups, and hearing a lot of speakers going through the pros and cons of this. Next slide, please. So we all went to work on Monday, enjoying clinic, not really thinking much was going to happen, and then suddenly it's on for young and old. There's another announcement. And so what's actually happened on Monday is that following the National Cabinet meeting, the Prime Minister has made an announcement that any person over the age of 18 who would like to have the AstraZeneca vaccine should now be discussing their options with their general practitioner. So it's a big change to what we were doing last week, but I think that with an appropriate structure we can manage that. And the reason I say that is the principles that are going to apply in these consultations when we invariably do them are principles that general practitioners know backwards and upside down and back to front. Because what we're talking about really is principles of informed consent and also of informed refusal, which I'll go through in a moment. But the approach that we will be taking will be that tried and true method of providing patients with the information that they need in order to come to a decision that reflects their own values and their own concerns. The vaccine experts like Margie Danchin, who has delivered some excellent webinars on this, really calls for any person having a discussion about vaccines to really approach the issue fairly, be honest, offer a true account of the facts, and not try to hide or sugarcoat things, and not try to mislead anybody with inappropriate information. We know that the more honest and upfront and clear in our information that we are, the better patients fare with their own decision making. And interestingly, the single most important person to influence a patient about their vaccine preparedness is their general practitioner. So I think we shouldn't underestimate just how much our patients do respect and listen to what we have to say. I think that's a wonderful thing, but I also think, just like Superman, with great power comes great responsibility. So we have to take that responsibility very carefully and respectfully. Next slide, please. So really, you can say that it's all going to boil down in some ways to the concept of informed consent and informed refusal. So informed consent, I think, is something that it's actually probably a term that gets bandied around a lot, but I'm not sure necessarily with all of our interactions with patients we actually do achieve what true informed consent is. So it's worthwhile just revisiting what it means to facilitate a person to achieve informed consent. And so if we're going to limit the scope of this discussion tonight to the AstraZeneca vaccine, of course, you're going to be starting about the risks and benefits of the vaccine itself. That's a logical starting point. And we will talk in a moment about how to be certain about what you're saying when it comes to risks and benefits of the vaccine. So obviously, we'll want to talk about the intervention that we're offering or the person is interested in. But we mustn't overlook the need to also talk about the risks and the benefits of not taking the intervention. And I do believe that in the Australian narrative at the moment, the risks of COVID itself is really only occurring on the periphery because we're utilising our island nation status as our key protective factor at the moment. The discussion about COVID as a disease entity is probably not getting as much airplay as I think it really needs to in order to achieve proper informed consent, because particularly with the Delta strain, the catastrophic nature of that virus, I really think shouldn't be omitted from any of the discussions that we're having. And I certainly would also argue that we can't reasonably expect to continue using a closed border as the primary mechanism of protection for our nation. So we're going through the vaccine itself, the risks and benefits of doing nothing, and then we also have to talk about the risks and benefits of the alternatives. And so there we have to advise patients that if they're going to use a different vaccine, what are the risks and benefits there? And I think we really need to make sure that we're up to speed with that information so as not to paint, a skewed view of the vaccine, because absolutely Pfizer has got its own side effects as well, and I think we need people to understand that, particularly anaphylaxis and the emerging evidence about pericarditis and myocarditis, which is in its own right a movable feast at the moment. moving on from that, you really can't say you've given someone the opportunity to make up their mind unless you answer the questions that are important to them. And that's where the values and the particular concerns of the patient become all important. So we have to really give time for patients to say what matters to them and what they're frightened of or concerned of, or what are their motivations for having the intervention in the first place. And then finally, and this one I hope doesn't require really any explanation, but if we only speak in a language that makes sense to us and not to our patients, then we may as well not have the conversation in the first place, unless the person knows what we're telling them. When we're not executing our duty of care for them. So it's not a small conversation really when what we're dealing with is rapidly changing and emerging medical evidence. So it takes a little bit of practice and developing a spiel, as it were. But probably the key message I'd like to make, and if we could just press forward on the slide just once, is context. Because, and this is where I feel we can go a long way in understanding ATAGI as an entity, if Nigel doesn't mind me speaking on their behalf, from my point of view, is ATAGI, understandably, is going to apply a risk-benefit analysis based on the context in which the person deciding on a vaccine is in. At the moment, because we've shut the country, there is not much circulating COVID. And so if you look at the risks of vaccination versus the risks of becoming sick or dying from COVID, the illness, ATAGI has said probably preferable for you to use Pfizer, because the risk of getting a clot from a vaccine versus getting a clot or dying or long COVID or whatever, given our context at the moment, we'd favour that vaccine. Now, I think it's really important to understand that context changes, as we've seen this week, literally within days. And I think that we need to be prepared to continue looking at the data. And if the risk goes up, we have to communicate that to our patients. In other words, these conversations about informed consent and refusal really do change in their flavour based on what is going on around us. And that's where I think a lot of flexibility in our conversations needs to be introduced, because this is absolutely so far from black and white. I couldn't think of a better example of shades of grey here. So we need to bear in mind the context. Before I move on from this slide too, though, I do want to point out that if a person says, I'm not going to have this vaccine or any vaccine, you wouldn't be able to say that you'd help them achieve informed refusal unless you were able to go to the lengths of explaining to them what the risks of not vaccinating is. I think informed refusal seems to be sort of the poor cousin of informed consent, and I think that we need to introduce that into our discussions as well. Next slide, please. So, sounds so easy. It's just a star with 5 points. It couldn't be easier. Well, absolutely not. This is actually a complex conversation, and I think all of us really need to be looking at our CHO updates and ATAGI statements and federal government updates so that we know what's happening in a rapidly changing world. There are a couple of sticking points, however, that I think it can be very helpful to have clear in everybody's minds. The first thing is, ATAGI advice is guidance from very, very clever, highly, highly nerdy individuals who love reading studies about what is appropriate in terms of vaccine usage in our current context. So that is guidance. It's definitely not a protocol. And that's where you can have the two programs going simultaneously. In other words, ATAGI saying it's preferable to have one vaccine and still be giving a different vaccine simultaneously. Those concepts are not mutually exclusive. because that's guidance from ATAGI in our current context, but it's not a protocol and it's not an edict. The thing that really does limit what we can and we can't do with drugs and devices in our country is the TGA. Now, the TGA says when you can and you can't use a drug for a particular thing. And although we do prescribe off-label, certainly in certain circumstances, backed up with medical evidence, this is one situation in which I would say the limits of the licensing that is provided by TGA must be adhered to absolutely. So the TGA has licensed AstraZeneca for use in the 18-year-old and above. And so that's why we're able in this context to say you can have a discussion and vaccinate somebody under the age of 60 with that product, even though ATAGI is saying it is preferable to use Pfizer. I think it's really good to know how the two organisations overlap and intersect. And of course, both of those organisations are operating in a very rapidly changing context. I think we do have a conservative TGA, which I think is a good thing. And we in Australia have also got the benefit of using billions of doses of vaccines from around the world to inform some of the decisions that are going on. The other thing we need to be able to advise our patients, and this becomes, a great source of confusion in the media, is because when they use this overarching term efficacy, no one really knows what people in the media are talking about because it's not made explicit, because there's different ways for a vaccine to be efficacious. And we need to make that clear to our patients. So vaccines, and we'll stick with the COVID vaccines and particularly AstraZeneca, it can be efficacious in terms of stopping you dying. It can also stop you going into hospital. It can also stop you getting the infection in the first place. And soon there will be emerging data about whether it can stop you transmitting to other people. And in amongst all of that information, that can then be stratified into the different strains of the virus that have now emerged since last March. So we need to be able to say that there's different outcomes here. So if you've got all of the vaccines that we have in Australia, the AstraZeneca, Pfizer, are very, very highly performing vaccines when it comes to stopping you dying and going to hospital. So that's a good thing. There is a difference in prevention of getting the illness in the first place. But I think particularly in this first iteration of our battle against COVID, and this is only year one of many, those two endpoints are probably all important. Hopefully over time, we will get increasingly better at just stopping infection in its tracks, but we're only at the beginning. So I think we need to bear that in mind. If you are fully vaccinated and you do get COVID, but your experience of COVID is the common cold that we all know and love, the vaccine's still been a raging success. Then moving on from that, we've got to talk about the risks of vaccination. And I won't go through that because Nigel has spent some time on that tonight. But I think we do need to be able to say to people the risks of vaccination do change depending on the age that you're in. And so you have to be able to give age stratified data, I think, which is actually available. We'll talk about where you can get that. As I've already said earlier, we can't fail to talk about the risk of COVID. This is really worrying to me. I really hope that our nation doesn't wait for deaths within Australia to become the motivating factor for participation in our vaccine program. I think we're all worried about the complacency that's out there. I don't want Australia to replicate situations like occurring in India and Indonesia before we decide to act. So we have to remind ourselves too that the whole purpose behind this program is to stop a catastrophic disease. Bearing in mind too also that dying is not the only bad thing that can happen to you if you get COVID. The sequelae following COVID can be truly life-altering. finally, there's sometimes you think, what is going on? There's two different messages. There's the medical guidance from, the epidemiologists and ATAGI, and then there's the government eligibility criteria, and that really is based on supply. And the reason I really want to point that out, I think that's so important, is we will all have conversations with patients where they will say, look, I'm 35 or whatever, I'm going to wait for Pfizer because it will be available in October. I don't think that we can say in good faith to a person that it is a certainty that the vaccine will be arriving at any particular point or will have any amount of doses at any particular point, because the production and delivery and supply of vaccines that are produced offshore is actually not within the control of Australia. We are reliant on overseas supply, and we have seen in the last 12 months just how fraught that can be. So I would just counsel people to be a little bit shy of saying with certainty, we will definitely have enough doses for everyone at a particular date, because we are reliant on a huge and complex supply chain. It's just not known. We certainly hope so. I certainly hope so. But there's a lot that could change. And I think we have to be respectful of that. Next slide, please. There are some really big concepts in giving people this information that I think we really need to work hard to help with. For example, the average person is probably not a great mathematician, and understanding risk can be really difficult. That's why we all take out TAPS Lotto tickets, because we probably don't really think just how ridiculously remote it is that event is going to occur in our lives. So I think there are a few things that would be helpful to reflect on. Firstly, in terms of risk, it can be very helpful to put risk into the language or into a paradigm that means something to the patient. And so there are new resources that have been created from the Commonwealth that provide a pictorial representation of risk, which I think is probably one of the best ways to do it for everyone actually, but certainly for lay people. But also for ourselves, for our patients, we do have to acknowledge, in medicine, I can't think of a single drug or a single intervention that is risk-free. So even taking Panadol, if you look it up, there is a person in Scandinavia who died from having a single 500 milligram dose of paracetamol. So nothing is risk-free. What we've got to talk about is at a personal level, the patient, within the patient's own mind, is the risk benefit sufficient that they will go ahead and be vaccinated because that is consistent with their values. For example, I vaccinated 2 patients on Tuesday who are under the age of 40, who are desperate for Australia to open up its borders because they've not seen their family for years and have a new baby, and the baby has had no interaction with family and they're desperate. So in their mind, with those values, they really want us to be moving into a post-COVID world, and they want to be vaccinated so they can travel. So I think we have to allow patients to explore their own values without necessarily us feeling the urge to superimpose ours upon them. I think our role is to present the facts and to facilitate people making up their minds. The reason I've put those 2 little screenshots there is I think we've become, the issue of risk is so important at the moment because we're seeing a global vaccination program underway. But there are things that are inherently risky as well that we probably don't pay as much attention to. So, for example, there's, in terms of having an anaesthetic in Australia, this is data up until 2011, the chances of dying from an anaesthetic was over many states, about 1 in 58,000. And so I think, and the chances of dying from an anaesthetic at a population level, that's not necessarily have you had an operation, that's just per capita, is 9.1 in a million in Australia. But I don't know if we drill that down every time we send somebody off to have surgery. The other thing too, in terms of risk, is we do prescribe opiates a lot in this country, sometimes for extremely good reason, other times perhaps less so. And the death rate from opiates at a population level, it's not actually data death per person who takes opiates, this is death per capita, is between 4 and 6.5 in 100,000 Australians. But I'm not sure that we go to the trouble of saying every time we write a script for Tarjan, do you know that 4 people in 100,000 in Australia die when they use drugs like this? So the reason I am making these points is that we are very, very heightened by the concern about these vaccines. And I think it is good to be very respectful of anything that we prescribe to a person that involves risk. But I think we also need to have a very balanced conversation. I think we need to understand our own reaction to risk compared to perhaps a much less emotional reaction to other risks that we take on for and with our patients. And then be able to present them with a fair and honest and frank discussion about the vaccine if they come in and say, I'm under 40, I want this AstraZeneca vaccine. Next slide, please. There's a lot to remember, and there's no way that I would suggest that that's easy. So I think aid memoirs are a great idea. I don't know if I've been packing away truly new facts in my mind since I turned 40. So I just use aid memoirs really. And this that I've got here on the screen is sort of hot off the press, I guess, from the federal government. It is a great PDF. I think we should all have it on our desktops. And it presents the numbers that we're all sort of hungry for. And it breaks it down into the relative benefits and risks based on Australia at a very low risk of COVID, Australia at a medium risk of COVID, Australia at a high risk of COVID. And by that, I mean outbreaks within Australia. I think it's also interesting to note, and I think we have a duty to report to our patients, that where it says cases of TTS, that is obviously cases of the thrombotic syndrome, but the case fatality rate in Australia is 3%. So of every person who gets TTS in Australia, there's a case fatality rate of 3%. And I think that's because we're going so gangbusters on our informed consent. Australians who are affected are recognising their symptoms very, very quickly and getting treated. And I think that bodes well for the effort that's going in to educate people who get vaccinated. Next slide, please. So I'm going to move on from the discussion about, holy moly, what do I say when somebody comes in and wants AstraZeneca tomorrow, to just a little update about what's going on advocacy-wise, from our states level and federally as well, because people who are involved in general practice really understand the pressure and the stress and the chaos that's going on out there. The first point I want to make is that the advocacy for general practice has been a multi-organisational collaboration that I'm very proud to have been a part of. So that's both colleges, that's PHNs, that's universities, individual doctors, a whole group of people who are going into that, talking about the story of general practice. I can say at a state level, we have a Department of Health that's actually very hungry and interested in the general practice point of view. And so certainly we've been speaking loud and clear to the vaccine expert advisory group in Victoria, and also the primary care engagement group in Victoria. And a lot of people listening tonight probably have been aware that there's been webinars aplenty for GPs, because we're wanting the information to flow very freely out into the community. I'm really pleased to say that the Victorian Department of Health did hear the request to divert doses into general practice so we could keep vaccinating. And we were the first state to suggest that that practice be undertaken. So I do think that there really are ears open at a state level for general practice. Federally, a lot is going on. I can really only speak for my own college here at a federal level, but I know a lot of agencies are working very hard with the federal government, and that's to increase the supply and the reliability of doses, to get the Pfizer vaccine into general practice, which is happening next week. The Universal Insurance Scheme has been called for, I can tell you, at a federal level for months. That has been a big project, and I'm really pleased that that's occurred. The request for national campaign in advertising to provide information to the whole of the country is a big ticket item that we've been working on for a long time. And also information for GPs. We want to be conduits of information. And then finally, I can tell you the funding conversation never stops. And I think everyone who's involved in general practice knows just what an impost this has been. And we're working really hard to get that recognised. So that's a Cook's tour of advocacy. I just want to reassure people that so much is going on. And if anybody has any questions, of course, go right ahead and ask them. But I think in terms of tonight, probably the single most interesting and important thing that we can provide you is a framework for talking about the risks and benefits of vaccine. So I will end there. Thank you.
Thank you so much, Anita. That was very informative. So we're about to go into some question and answers, but I'm just reminding you that the pathway we're particularly talking about, this is the links to them, and obviously for your password and username, most of the GPs who have logged in tonight will know those, but if you're new to this, then you'll get a very quick response once you email your local PHN for that. Next slide, please. And with the pathway, if you have any feedback or any pathway you see on HealthPathways, there is a send feedback button, and that will come direct to the PHN, which will get forwarded to any clinical editors, any errors that you see that sometimes occur or anything that you feel needs to be raised, and that's a great place to do that. Thank you for everyone who's participated this evening. It's been fantastic.
Thanks very much, Scott. Thanks for the invitation.
Bye-bye.
Yeah, thanks, Scott. Thanks, everyone. Bye.